Are you doing Good morning. Welcome to the inaugural meeting of the Care Delivery and Transformation Committee in our new committee structure. Also have Dr. Kreider, newest member of the Health Policy Commission, and Dr. Berwick. Unfortunately, both of them are traveling today, so we're unable to be with us. But we do have a quorum, so we'll move ahead. And our first order of business is the committee chair appointment. So I'll leave that to my fellow committee members. Pursue a nomination.
I'll nominate you.
All right. All those in favor? Wonderful. Be careful what you wish for, right? Okay, our next order of business is the approval of the minutes of what was the joint care delivery and quality improvement meeting back in October of 2017. Motion to approve those minutes. Motion. Any changes, corrections? Not hearing any. All those in favor? All right. Motion carried. So we have a fairly packed agenda today. Just to let people know, we're going to go over the proposed risk-bearing provider organization (ACO) appeals regulations, moving us from some of the interim guidance that we provided over the past year and a half to actually promulgate regulations, and then an update on the patient medical home crime program, as well as some information about accountable care organization reporting. We also today are pleased to have a guest presentation on our neonatal abstinence syndrome investment from the folks at Lawrence General, and then we're getting a preview of the notice of the spring care delivery event, which will be held on May 17th. So our first order of business is to look at the proposed risk-bearing provider organization ACO appeals regulation. And we have Nancy Ryan and Steve Bellin presenting.
Sure. I just wanted to say that we're very excited to be presenting this at the inaugural committee meeting, and this is has been a project a long time in coming. We've taken a very deliberative approach to developing this really first for us and probably first in the nation consumer protection that is analogous to the current protections that we have for consumers of commercially insured health plans. And so Nancy Ryan of my team and Steve Boak, the director of the Office of Patient Protection, are going to walk through the purpose of this regulation and some of the key important features. But as you say, as you noted, we really are building off our experience the implementation of the interim guidance, and so which was a sort of a key design element here that we proceeded with that on the internal side, and now we're going to build out the external review process. So I will turn it over to Nancy.
So the first slide here just goes over the statutory requirements, which we've seen before. And these again are appeals where a patient can challenge a provider's decision. And the two key elements required by statute are that OPP oversee internal appeals at the provider level and facilitate independent external review for patients to have that second voice there to decide their appeal. And the statutory requirements that we just saw are similar to OPP's current carrier requirements around appeals processes. And likewise, the same concerns that led to patient protection in the managed care context, sort of in the late 90s, early 2000s, are the same concerns that arise when providers are taking on more risk, as we see currently. And this patient protection is sort of a limited protection for a small set of patients who might have issues accessing care in this current environment. And since it is so similar to the current carrier external review process, we wanted to just sort of remind commissioners of how OPP administers the current carrier external review process and how that works for patients. So currently how it works is that a consumer sort of remains aggrieved after they get their decision from internal appeal from their health plan. And the consumer then submits a request for an external review, that independent voice, to OPP. OPP reviews that for eligibility and then sends that request to an external review agency for that clinical decision making. The external review agency then contracts with clinical experts to review all the medical records, review sort of the patient side of the story and the carrier side of the story, and then comes to a final written decision that is then sent to the patient. There are some sort of important differences in the process that we're hoping to promulgate regulations on here and the carrier process. So the process that we're going to talk about today really revolve around provider decisions, focusing primarily on sort of access to care, whereas the carrier decisions are about coverage and whether that care will be paid for by the carrier. So the types of issues that have been sort of working themselves out in the interim guidance as appealable issues, and ones that we propose continuing to use as we promulgate regulations, are referral restrictions, type or intensity of treatment or services, and timely access to treatment or services. So these are the issues that patients will be able to challenge their provider decisions on. And there are some overlap in the different sort of appealable issues here, but what it really comes down to is who is making the decision. Is it a carrier decision or is it a provider decision? And the types of issues here would be provider decisions for the RBPO, ACO appeals regulation. And as Lois said, we've taken a deliberate process to sort of developing regulation and have done quite a bit of work for a number of years in sort of figuring out what the best process is, learning from the provider organizations, and that culminated in sort of releasing the interim guidance in April 2016 and working with the provider organizations to implement that such that the interim guidance has been implemented by the RBPOs and ACOs since October 2016, meaning that the RBPOs and ACOs have had internal appeals processes in place since that time for over a year, and we have been working with them since then to make sure things are sort of going smoothly. And Steve's going to talk a little bit more about our latest work.
Sure. So as Nancy mentioned, we're continuing our multi-year regulatory development, fairly prudent process, I think. And we've been monitoring the implementation of the interim guidance over the last 15 months. Organizations have been providing quarterly reports to the Office of Patient Protection. We've been reviewing those reports for compliance and other noted concerns. Furthermore, we've continued our robust outreach efforts to all stakeholders, holding targeted compliance calls with certain entities, holding technical assistance calls with folks who are actually implementing this process on the front lines, and just further addressing any noted areas of concern as we've heard them from either patients or other stakeholders. We have received a small number of inquiries pertaining to this process, primarily just folks working to understand what is an ACO, what is an RBPO, and how does this process apply to me, which I think indicates that the noticing requirements were functioning well as provider organizations were putting them in the regular places of care. We also, continued outreach efforts to other stakeholders, held an additional listening session with the RBPOs and ACOs. We met with other state agencies. We convened other consumer groups and discussed the issue with certain subject matter experts, primarily being our 3 currently contracted external review agencies, as well as the accrediting body for those agencies, URAC. And for the most part, I think by and large, feedback has been pretty positive. It took some time, I think, to integrate this process. We were encouraging folks to build upon existing mechanisms to address certain patient concerns and really not, recreate the wheel here. And in the listening sessions, we heard back from the RBPOs that, yes, this is working well. And then when the consumers were contacting us, they said, yes, I was advised of my rights to appeal, and I pursue that process. I just wanted to work to understand it better. And then we'll move on to some of the details of the report. So thus far, we had 23 organizations reporting to the Office of Patient Protection. I think moving forward in March, we expect that universe to shrink a little bit. These are the organizations both who are certified by the Division of Insurance as risk-bearing provider organizations, as well as these HPC certified accountable care organizations, but is sort of a limited purview of only those organizations that provide direct patient care. And then the applicability of these proposed regulations also will only pertain to commercially insured patients who are then attributed to commercial at-risk contract in that provider organization. So it wholly excludes any Mass Health patients and any Medicare patients. We are working closely, I think, with Mass Health, but they have existing consumer protections and safeguards in place under state and federal law to address those types of appeal issues. And the same with Medicare, that is true. And I think invariably consumers will seek out assistance from the Office of Patient Protection, just given our name, even if they are Mass Health members. So we'll work to better understand the Mass Health process so that we can properly advise and refer members as appropriate. So over the last 15 months of reporting in aggregate, we heard of 98 total appeals, and predominantly those appeals pertain to referral restriction issues, about 8 out of 10 appeals. And this is overall, I guess, a small figure, respecting that we estimate the total universe of impacted patients to be about 1.5 million commercially insured individuals, sort of attributed to these at-risk contracts. And given just the total number of 100 over the last 15 months, we think that the folks who, of those appeals, I think a majority received an unfavorable outcome, as reported by the RBPOs, but as reported by the patients, they were sort of satisfied with that unfavorable outcome. So once, say, the referral restriction, which was the predominant reason, was limited, and then they pursued the internal appeal process, and then that process was upheld internally, that patient then sort of engaged in a conversation with the provider and kind of had that shared decision-making conversation around coordinating care within the ACO, and then we're sort of satisfied with the outcome of keeping that care within the ACO or RBPO. So we think, the total universe of folks who actually avail themselves of this external review process will be fairly small moving forward.
Steve, can you give us just one sort of example that's up from the 98 sort of demonstrates what the issue was?
Sure. So we heard of a few, at least, issues from patients where the ACO was referring them to a specialist within the ACO. The patient was usually fairly new to this ACO structure, and may have had a prior relationship with a PCP, but hadn't seen that PCP for a while, but had ongoing care needs with a specialist that may have been located outside of the ACO, and so they wanted to continue that relationship with the specialist outside the ACO. And then once they met with his primary care provider, realized that may not be feasible. And so they then met with the primary care provider and then a care coordinator, and then sort of understood that within the ACO, here's the available network of providers for you, here's the areas of specialty and their expertise. And then moving forward, they were satisfied in finding a provider that could meet their care needs.
Move on to the proposed regulation. So some of the considerations in regulatory development that we touched on already is that we wanted to follow along with the interim guidance, knowing that it has been implemented well, and also wanted to closely track the carrier external review process as we develop a sort of parallel process within the Office of Patient Protection. So with those two concepts, working to clarify expectations of both patients and the RBPOs and ACOs, and also reduce the reporting burden, which we think will be a welcome addition. We've already sort of gone over the applicability in terms of patients and the RBPOs and ACOs, and also the issue subject to appeal. So we'll skip that one. And also, like we said, the internal appeals process follows pretty directly from the interim guidance, and in addition, the internal appeals process is based in statute in terms of the statutory timelines that the RBPOs, ACOs must follow, and then also the sort of statutory prohibition against terminating medical care during the appeal, and the also requirement of the appeal not be in writing as an access issue. Not only but sort of the main key and new element of the proposed regulation is the external review process, and this is not contained within the interim guidance and will be a process that OPTP will be administering. The timelines, again, are not identified in statute for the external review process, so we developed these timelines considering sort of what was in statute, the internal appeals, and how the carrier appeals process has gone, and think that considering the types of issues that we expect, these are sort of reasonable timelines to propose, and expect sort of feedback and welcome that feedback on what is reasonable for a patient and what is reasonable for the external review agencies as well.
Can you highlight some of the differences where there are some deviations from what the current Maxwell PCO previous processes?
Sure. So one issue, at least on the internal appeal side, is that the Maxwell grievance process is a 30-day timeline, and this process statutorily has a 14-day timeline for a standard appeal. So that is one difference where RBPOs and ACOs who are sort of who have both sets of patients will have a slightly different process potentially. In terms of the external review process, if we're taking a parallel of the Mass Health sort of board hearing, the 30-day timeline for a patient is the exact same timeline that a patient would have to bring a Mass Health concern to the board of hearings. So that's consistent. We at OPP don't have the sort of medical expertise in-house or the sort of long history of the board of hearings to be able to decide these in-house. So the OPP will send out to external review agencies, which will contract with the same plan that we contract with for the carrier process. Those will be 3 external review agencies. We anticipate at least 3 that will rotate throughout to sort of make a fair and independent process. There is a process for expedited, which I think is similar to Mass Health. And in this case, one thing that is worth noting is that the involved RBPO or ACO will pay for the external review. There are around $400 to $800 each, depending on if it's expedited or not. This mirrors exactly the carrier process, in which the carrier pays for the external fee.
One other just data point is there are some certified ACOs that just have mass health lives. Right, they have been certified because mass health requires them to, they will not be subject to this process at least.
This just goes over a little bit more sort of visually about how the process will work for consumers. You may notice this is identical to the slide that we presented before, but a consumer, again, in this case, will receive a written decision from the RBPO or ACO, and then, like we said, have 30 days to submit an appeal to the Office of Patient Protection. The Office of Patient Protection will review it for certain eligibility standards that are outlined in regulation, and then send that request to an external review agency. The external review agency will review medical records. In this case, it will be particularly important to hear sort of the patient's narrative, I would say, and any medical records that are submitted, and then also the medical records and any additional information from the RBPO or ACO. And then they'll decide within either an expedited or a standard time frame, and then send that written decision to the consumer directly. So OPP, acts as a resource during this whole process, but doesn't actually make any of the sort of medical decisions. And in this case, also, what we envision is that OPP would send out a request for expedited review also to the external review agencies to decide whether there's an urgent medical need and it warrants expedited review. The standard of review is one of the key issues that we had to decide, and we're looking for feedback on in terms of the proposed regulation. There is no statutory standard of review here, and we looked at an array of standards, including the carrier medical necessity standard, and came up with this one as a proposal. The standard that we're proposing that the external review agencies use to decide the appeals is whether the treatment or service or referral is likely to produce a more clinically beneficial outcome for the patient. And then we also are proposing and looking for feedback on the factors listed below that we are, think it would be wise to mandate that the external review agency.
Is language one of those with the external review process that there's availability for folks that don't have without speaking English language?
So it's not listed sort of with that specificity in the proposed reg as we have it now. Access is definitely sort of broadly speaking how this process differs than the carrier process, including sort of language access, geographic access. The factor that we think that fits into is sort of other factors relevant to the patient's ability to access the requested service. We think that is comprehensive enough to bring in those non-clinical, non-medical factors that may inhibit the patient from seeing the person within the RBPO or the treatment.
Our intent with the proposing this last somewhat of a catch-all factor is broadly access. It could include language, it could include geography, just other things that would be a barrier to that patient receiving care.
Is this similar to the standard used in Maxwell in terms of this seems to be a fairly, well, it's not that high a bar in terms of this standard, and is this comparable to what is used either in Maxwell or other ACO models of PCMH?
So both Mass Health and the carrier, the commercial carrier process is medical necessity standard, which is identified in statute. We considered the medical necessity standard, but thought there were sort of different aspects here in terms of there's, like Commissioner Foley said, there's issues of access that aren't necessarily addressed in the medical necessity standard that we thought could be addressed in a standard like this. Secondly, this process might bring up questions of sort of comparative treatments and comparative providers that could be, providing a particular service. And we thought that because of those issues that might come up, this standard would also encompass those decisions, potentially better than medical necessity. The other reason is that just for sort of administrative patient and to avoid confusion, we didn't necessarily want to have the same standard as the carrier process. It would be possible that a consumer would be able to go through sort of both processes at different times, and we thought that we would avoid that confusion, having the same exact standard. But we do think this is a a relatively high bar, but also that also encompasses all the factors that may be at issue in a new process like this. And this particular standard is based in New York insurance law, and we looked across medical reviews and legal reviews to figure out sort of which had a basis that we could use.
So can I just ask, where in the regs, or you're not outlining other factors relevant, where does that play into the regs?
Yeah.
So I'm just looking for the language that gets the catch-all and if it meets the.
So the language on the slide is identical to what's in the
In the
proposed
document.
regulation.
Okay, gotcha.
The last sort of key element is the reporting, which we've already talked about. It's going to go from now quarterly reporting system to annually. So reducing the reporting burden, also reducing some of the elements in the reporting as well. So it allows us to monitor what's going on, but not be too burdensome on the RBPO ACOs as they've been so helpful in getting this process started. This is our timeline according to the board schedule as it is now. So if there's any other questions or comments, I'm happy to fill them.
So the next process would be a public hearing, public comment period, followed by formal hearing and promulgation of the regs.
Yes.
Right.
Yeah, we anticipate putting sort of this draft version of the proposed regulation on our website if people would like to view it. The actual official sort of public hearing comment period would be after the board would vote likely in April.
So we don't need a board, the committee would just right.
Yeah.
Right.
Yes, just following up, looking at the total number of appeals versus the approximate patient population that be covered by this. Is there a disclosure or any reporting on if, say, the 98 all came from one risk providing organization? Like, is there a public report of like where these are coming from, or is that confidential information that we share and saying if there's a pattern of certain folks that this has happened to risk bearing organizations versus others, that information that's publicly available or shared or discussed here?
So one of the things that we've noticed in we've used the interim guidance process to really be a learning exercise for us, and one of the things that we've been mindful of in this process is the sheer variety of different types of organizations. Some have been at this a long time under risk. Some are organized in a way that's for lack of a better word, more ACO-like, and they really do try to manage referrals, stay outside of the system. Others less so, they're less organized. And so one of the things we're just mindful of that it's at this point it's not an organization is doing poorly with respect to consumer access because they might have more appeals. They may be doing a very good job, in fact, of giving notice to consumers. So we don't want to necessarily want to paint organizations in a positive or negative light here. And I think the same was true very early on in the early days of OPP, where some payers may have done a good job of giving notice to patients about their appeal rights. So I think it's a sort of a learning process. And that is, of course, though something that we keep in mind, monitor as we do with payer concerns that come to OPP. If we're getting a lot of calls about a particular issue, we can pivot and try to reach out to that provider or payer.
Could that information be made public about who's these complaints coming from now?
Yes, we do anticipate the reports that will be filed with OPP with the public.
Any other questions? Thank you. agenda, we have the patient-centered medical home crime program update. Captain Harrison.
Hello, everyone. So I'm providing an update today on PCMH crime certifications and specifically on our TA program. So here we have our current PCMH crime participation numbers. Currently, we have 78 practices that are PCMH crime certified. We've had a lot of certification activity over the last few months, excitingly. So in December, we had 18 practices certified. In January, 17. And up there, Family Medicine North is our latest certification that happened since the last board meeting. In addition to that, we have 36 practices that are still on the pathway to PCMH crime. So, to provide some context for our technical assistance update, as a reminder, we wrapped up the first cohort of our TA program back in November. And on this slide, we have an overview of participation in the various TA modes that we posted. As a reminder, we had 20 total practices participating in TA. About 6 of those were PCMH crime certified at the beginning of the cohort. Of those that were on the pathway to PCMH crime, 50% so far have since achieved PCMH crime certification. And I'm also hopeful that the remaining practices on the pathway will be able to apply for certification in the coming months. Overall, we received positive feedback on the first cohort. We heard from practices that TA was helpful in helping them understand and implement best practices in PHI generally, as well as helping them achieve specific PCMH crime criteria.
Just as a reminder, the TA included direct practice coaching, 2 practices by the HMA staff, 2 learning collaboratives, as you see here, which were bigger events that were topically focused on elements of organizational change and leadership development, and then specifically sort of care flow, care model designs related to behavioral health integration. And then a number of webinars that HMA put on that we will be posting on our website relative to different aspects of behavioral health integration. So that was the whole TA program.
And I'm happy to announce that this week we're launching a restructured version of our PCMH crime TA program. As we previewed this, I think, at the October CDT meeting. But the idea here is we're redesigning our TA a little bit just to better focus on meeting individual practice needs and reducing barriers to practice participation in technical assistance. So with cohort 1, we're going to continue to partner with Health Management Associates to deliver content focused on using the collaborative care model to integrate behavioral health into primary care, as well as having some content focused on, again, certain specific PCMH crime criteria. And we'll continue to offer many of the same TA modes that Katie mentioned, knowledge sharing sessions, practice coaching, and webinars. What will be different is what we're moving away from that, the structured cohort structure. So previously, we required practices to commit to participating in multiple modes of TA over a structured timeline. And to build in more flexibility, going forward, we're going to offer 3 different modes of TA, and we will allow practices to kind of mix and match, participate in whichever modes I think really is most appropriate to their particular needs and capabilities. So we'll continue to offer knowledge sharing sessions, practice coaching, and 7 pre-recorded webinars. The coaching and webinars will be available to practices on the pathway to crime or certified practices. And then knowledge sharing sessions will be open to any practice in the state. So, provide a little bit more detail about our knowledge sharing sessions. We plan to offer 4 of these events over 2018. And these events will be in-person, peer-to-peer learning opportunities focusing on a variety of behavioral health integration topics. This is something we keep hearing from practices, having these opportunities for in-person networking and learnings from other practices doing similar projects is really valuable. So that's really the focus of this mode. So our first event in the spring will focus on telehealth for behavioral health integration. And then over the course of the year, potentially hoping to have other events on financing behavioral health integration in primary care, managing patients with serious mental illness in primary care, as well as using team-based care models to support increased access to behavioral health care. So more to come on all those in the coming months.
We'll be doing them in different geographies,
Yes.
not just ones.
In addition to those knowledge sharing sessions, Pathway to PCMH Prime and PCMH Prime certified practices can now sign up for up to 20 hours, or can now apply rather, for up to 20 hours of individualized practice coaching from HMA staff to be delivered over up to a 6-month time frame. And to apply for this, practices just need to fill out a simple application that describes their coaching needs and the project they would need practice coaching support on. That will be, practices can find that either by emailing us, and we'll be posting on our website as well in the next few days. We'll be reviewing these on a rolling basis, and we do encourage any practices hoping to reinstate in 2018 to apply by June, just for resource purposes. And to wrap up, this is just an overview of our work over the fall and key dates over the spring. So again, in addition to currently accepting the practice coaching applications, we're hoping to have the first knowledge sharing event in April, and hopefully another in early summer.
From the first year of the technical assistance, are we seeing any needs that we didn't anticipate a year ago, or that are coming up from the patient-centered medical home? And I'm particularly interested in the behavioral health integration, because I'm reminded by Secretary Sutter's comment at last hearings about really achieving true integration, which is yet to accomplish. So I'm wondering, are we going wider, or are we going deeper with this year?
It's a good question. I think based on the feedback we received, a little bit of, there are a few places I think we can improve. In terms of content, I think over the first cohort we saw that there were some PCMH Prime criteria that the TA was a bit more helpful on than others. So for example, I think we can maybe, for example, in the PIS events, do a little more work to have speakers talk about kind of SUD and how to kind of integrate that into practices, for example. There were some other topics like financing for VHI that some practices said were helpful, but we're hoping to have another KISS event on to really maybe go a little bit deeper or in that topic. So I think it really varies by specific criterion. And yeah, in terms of general structure of TA, I think kind of one challenge is that these in-person sessions are both valuable, but it's also sometimes hard for practices to get away to attend these events. So that's something we continue to struggle with and try to do in a flexible way.
Any other questions on the PCMH? Thank you. All right, moving on. We have a update on accountable care organization reporting. That gets to stay.
Yes, thank you. And Commissioners, I'm joined by Courtney Anderson, who I'm pleased to introduce. Courtney is really leading the development of our reports based on ACO certification data. So she's going to keep me honest as I present this content and help me answer any questions you might have. Okay, so overall, the purpose of this portion of the presentation is really to share with you the plans that we have for analyzing and reporting the information that we received from the first round of ACO certification over this past year. As you know, ultimately certification is not just about holding these organizations accountable for meeting different standards, but really also for collecting information about how ACOs operate and trying to create some more transparency in the market. So that's really, the primary aim of our reporting structure. So we've given some thought to the approach that we'd like to take, and we'll walk you through that today and look forward to your comments and feedback and discussion.
But first, let me just reiterate the announcement that our executive director made at the last board meeting, which is that as of late last year, the HPC has certified 17 accountable care organizations. So these, again, represent all of the ACOs that are participating in MassHealth's new ACO program. Although, as you also know, our certification is not specific just to the MassHealth population, so we reviewed these provider organizations across all of their risk business, including commercial and Medicare where applicable. So before we get into the full reporting proposal, we did put together just a few top-line data points for you from kind of some initial reading that we've done through some interesting summary statistics that we thought would whet your appetite a little bit for the discussion to come about reporting and what we plan to put out over the next year or so. So on this next slide, there are just a few things here that we pulled together from the application responses that we found interesting. And I will mention just a few of these. I think starting with perhaps an unsurprising but important fact about the ACOs that we certified, which is that 82% of them, that's 14 out of 17, are anchored by at least one hospital. The other 3 being a physician-led model, either an integrated delivery system or a group of practices coming together for the first time. Across our 17 certified organizations, there are 66 commercial risk contracts and 11 Medicare ACO contracts, covering all about 1.9 million Massachusetts patients. Also notable, 5 of the 17 ACOs hold at least one commercial risk contract that's for a PPO product. I know that's something we've been tracking as an agency over time, and I'm sure we'll be wanting to delve into that a little bit more in our reporting.
That is an area where we have a number of confidentiality protections on this data, but that is which risk contracts do you have and with whom. It's one of those areas where we are able to disclose a little bit more information, similarly to kind of family and patient engagement processes. So I found this very interesting. I think it's been a topic of debate at the cost trends hearings, and borne out in our most recent APM data in the cost trends report that we just saw at the last board meeting. Blue Cross is moving ahead with PPO risk contracts, and that's exciting. So just a couple of other interesting facts here. Most ACOs have a 50% or higher rate of NCQA PCMH recognition among their primary care practices, which is nice to see. And 41% of ACOs have at least some practices that are working toward PCMH prime certification. So obviously this is just a quick snapshot without a lot of detail or context. What we do really want to be able to do is put together a reporting strategy that will go deeper into some of these important areas and provide, obviously not just factoids, but some more analysis. So let's talk a little bit about what we want to do. This is just a reminder of the criteria that we used for certification. The assessment criteria, as you know, there were 6 of them. These were the standards against which we really evaluated ACOs to determine whether or not they met these standards or these criteria. Most of the responses to assessment criteria came in the form of a narrative. So what I mean by that is we asked a question and the ACOs drafted a new response specific to that question, or they might have used an existing document that they had already around that answers the question, uploaded that to the application. The point here is that there's a lot of variability from one applicant to another in exactly how they address these questions. So when you go to think about how do we analyze this data, it's a bit of a challenge. A lot of the work that we will have to do putting together the analysis of that section and those assessment criteria will be pretty manual. This is not sort of a plug and play kind of approach where you get a master spreadsheet and churn out a bunch of stuff. In some contrast, the required supplemental information questions came in the form of more structured data. So this was a group of questions that we asked ACOs to answer, largely in the form of checkbox, sort of yes/no answers or multiple choice. There were some sort of freehand short answer responses, but a lot more structured data that we can use here and do, some more quantitative type of analysis.
as Katie was just alluding to, another very important thing to keep in mind as we begin to have this conversation, commissioners, is the confidentiality protection surrounding much of the information that was submitted to the HPC for ACO certification. Most ACO certification application contact can be publicly reported by the HPC only in aggregate, not specific to each ACO. So without the consent of individual ACOs, the only data elements that we can publicly report on in an identified way are these ones that you see in the gray box. So the basic contact information, this piece about the position of the patient or consumer representative within the governance structure, and a little bit about what kind of public narrative the ACO has around its approach to patient-centeredness, and then the names of the payers with whom the ACO has risk contracts.
So we can do a lot of by the numbers, lots of by the numbers here, not a lot of, the specific ACO does this unless of course they consent to it, and very few consented to specific parts of their application being able to name them. So that's not to say that we can't go back to them later and see if they want to engage in a process by which we can share more of their information about.
Right. How does that compare to the Mass Health standard? Is that also the same confidentiality issues, or is that more publicly available information?
I don't know the exact answer, but I would assume that there are confidentiality restrictions.
Their contracts, like almost health contracts, are public documents, similar to Medicare contracts with ACOs. This is a little bit different because this is data relative to a certification program, and so I'd liken that more to Mass Health's ACO readiness process that they're going through now. What are you doing around population health? It's a little, the contract being redacted may be publicly available, but I see this process a little bit different than the contract that Mass Health has with ACO process.
Right, so I think the bottom line here is while a key goal here is transparency, we'll have to achieve that by reporting more in an aggregated form than about individual ACOs specifically. So on that note of goals, here are some of the goals that we've developed to try to guide the approach that we've determined to propose to you all for reporting. These sort of may seem obvious, kind of mom and apple pie kinds of things as goals on a slide like this often do. But of course, if we're off on one of these or we're missing something important, then we may get off track in terms of what we're proposing to report. So I think it's worth going through each one of these in a little bit of detail. So the first, of course, is to enhance transparency in the market. We've talked about that already. We're looking to contribute to the evidence base on current ACO operations and approaches. This is an important part of the learning that we want to be able to achieve through this program for the interested public, for other providers, and other key audiences that we'll talk about in a moment. We want to deliver accurate, relevant, actionable information for stakeholders, again, for providers that are looking to improve their capabilities. We think there's an opportunity here for our reporting for that to happen. We also want to push the envelope a little bit in highlighting important topics and promising approaches in care delivery transformation work that are near and dear to us at the HPC and we think may be underrepresented in day-to-day ACO operations. Certainly through this process, the HPC is interested in learning and using what we've gained through certification to inform the development of future ACO certification standards and programming. So this is a feedback process, right? We put out standards, we get stuff in, we look at our standards again and say, where do we go next? And we'll certainly be doing that in this process. And finally, of course, we're trying to contribute to the HPC's overall policy agenda and goals in both market performance and care delivery transformation. So if those seem like good goals, let's talk a little bit about key external audiences. The groups that we think are the sort of key audiences for our reporting efforts from ACO certification are policymakers, providers, including the certified ACOs and others, maybe some providers who aren't part of ACOs yet as well, payers, purchasers, and employers, and then generally media, researchers, and the interested public. There's some commonality across these groups in the kinds of information that we think they'll be interested in learning from certification. So for example, we think providers and payers both will be interested in understanding more about how ACOs operate from their business approaches to how they run population health management programs. Some of those strategies may be employed by other providers. Payers may be interested in learning this kind of information to inform their relationship and contracting strategies with providers. So we think that's one example of an area where we'll have a lot of interest and attract audiences to read these reports. And some of the things will be more specific to individual audiences. So for example, we think policymakers will be particularly interested in knowing about any barriers that we are able to identify through ACO certification to further adoption of these models. And we're looking to the payer, purchaser, employer community to engage with us as a result of these ACO certification reports and find new opportunities for collaboration in terms of standardization across the Commonwealth in our value-based care messaging.
Yeah, and just pausing it for a minute to bring back the PPO point, I think this is a very important audience for us. I think we've seen kind of a stalling in APM rates due to self-insured and the lack of progression into self-insured and PPO. And so this, having this bucket understand what ACOs are doing, what value they're bringing to patients, what is the evidence base for them as we're learning through this program will be really important. And so, we'll come back and look for your feedback on best ways to do that.
I think with these 4 audiences, we're covering a pretty wide swath. The one group that I'll mention that we're saying is not a specific target of these briefs are consumers, and particularly we know that Mass Health is going to be doing lots of outreach to their patient population, and they're really already out there with the new Mass Health Choices website and member handbooks and a lot of other extensive outreach. So of course these reports will be publicly available. We'll be posting them on our website. We'll be distributing them widely, and we would welcome any engaged and interested person in reviewing them and giving us input on them. But in terms of sort of trying to guide people around enrollment decisions or choice of sites of care, I don't think we're going to be getting into that kind of territory with these reports. And I think it's important to note that and not to step on the work that's already been being done in Mass Health and other realms on that. Okay, so last kind of framing slide before I get to the punchline on our proposal here. Just 2 more key questions that we grappled with and asked ourselves in the course of designing our approach. So the first is, how much of the content that we receive through ACO certification should we be trying to put out? Should we be trying to be fully comprehensive, reporting out as much as we possibly can that we learn? Or should we be a little more choosy, a little more focused, and pay most attention to reporting on areas of particular salience to stakeholders? I think in the proposal I'm about to share with you, we're leaning a little bit more toward the salience to stakeholder interests category. We want to make sure that the topics we choose to report on are really going to go somewhere and really contribute to the knowledge base, rather than being too much just a comprehensive data dump, which could be a little overwhelming and maybe less useful. Second, we thought about, and we continue to, the appropriate balance between timeliness and quality. So getting stuff out as quickly as possible versus being as rigorous as possible in our analysis. And here, I think in our proposal, we're really trying to get kind of right down the middle. This is a tough one, but we obviously would never want to put out anything that wasn't 100% accurate and we couldn't stand behind from a quality standpoint. That would be foolish. From a timeliness standpoint, though, I think we are aware that the longer we hold this information, the staler it gets. And particularly since this was a point-in-time application, we want to be sensitive to bringing important information out into the public space as soon as we can, as quickly as we can, so that we're actually just not too stale by the time we get out there with it. So with all of that in mind, this is the kind of bottom line of our proposal for a set of ACO certification data briefs, or calling briefs. This is quite a busy slide, so I will walk us through, and I would point you mostly, commissioners, to the sort of yellow-orange boxes that highlight the topics of the 6 briefs that we're proposing to put out. So again, we would be creating and releasing 6 briefs on the short side, 2 to 5 pages, a mix of text and graphics wherever possible, images, organized by topic areas that we think are of key relevance to stakeholders. We are aiming to release them once about every 3 months. We will try to front load a couple of the first ones, potentially in a shorter time frame than that. But again, we'll be trying to balance that timeliness quality divide. And in terms of the point about comprehensiveness, we would like each of these briefs to stand alone on its own and be understandable if someone just picks up one of them. But together, we do hope they will tell a pretty comprehensive story about the landscape of certified ACOs in Massachusetts. So the first brief that we are proposing to put out in the next 2 months, it's coming up fast, is meant to be kind of an intro to accountable care organizations in Massachusetts. And we would do a couple of things in this brief. One is introduce some key terms, put our ACO certification program in context, report on the number and the names of the certified ACOs, provide perhaps some of those same snapshot quick facts that I previewed at the start of this, and kind of set the stage for the reports to come. We're also planning and hoping to be able to put out a profile of each of the ACOs. Now, this is made a little bit complicated by the confidentiality protections we're under, but we have some hope that joining up with our colleagues at RBPO and looking at some of the data that they have, which is public data, we might be able to put together a profile of each organization that at least blends some of the system level public data that RBPO has with some of the elements of ACO certification reporting that we are able to report on an individual basis. So our heads are still forming around that topic. We'd like to put those profiles out in partnership with, or in close alignment with that first brief, so that it really does a nice job of laying out the landscape. The timing may not align perfectly, but that's our hope. When we get to brief 2, this would be maybe in the late May timeframe. The topic we'd like to focus on here is how ACOs manage population health, particularly behavioral health and social determinants of health. And this is going to come really from a couple of key questions in our certification data. We asked an assessment criterion question basically about their population health management strategy, approach to risk stratification. We think this is a key topic of high interest. It is at the HPC. And putting out this brief in the spring would also align with our spring event that we'll be talking about a little later. So that would be brief 2. The third would focus on how ACOs manage risk contracts. This, again, I think is a topic we think will be of high interest. The fourth would be how ACOs are governed. And this one would focus on elements of governance structures that perhaps would be a little bit more limited in interest to the more legal community, but we think there's some interesting information here about how ACOs organize themselves, what kind of distribution of people they have on their boards, voting rights, that kind of thing. So it might be a little dry for some, but we think it has some important relevance to the conversation overall. Brief 5 would be a combination of a lot of different questions, all related to patient-centered care. So we think this could be a nice way of describing ACO's approaches to everything from NCQA medical home recognition to their assessments of their patient population and what kind of information they try to collect in order to better serve patients. And finally, we would do a brief on ACO's relationships with other providers, how they coordinate care across the continuum. That series of 6 briefs would take us, a little over a year probably. And as I say, I think does a fairly comprehensive job of describing what we learned in certification, but hopefully in a way that highlights, particular pieces that stand out to us as important.
Is there enough there in the data to be able to produce these, or will it also require some additional conversation and outreach?
I think there's quite a bit there. We will undoubtedly be talking to ACOs throughout the course of our work here. We don't have a formal requirement in ACO certification for additional reporting. So, certification is a 2-year cycle, and ACOs are not, for example, required to resubmit their applications. We do ask them if they have if there's a significant change in their ability to meet the criteria. They've implemented a new process, or they've, for example, changed the way that they're going to structure their patient family advisory committee. We're clear that we ask them to notify us in those cases. I think that we will be, really mining the information we have. I think we have a lot to go on. Certainly, we'll be looking to other data sources. I mentioned RPO. There may be information that's coming from our colleagues on the strategic investment team who are working with systems now in the context of CHART. In the context of our new investment program, Shift Care. So I think we'll probably be doing a mix in the end of information we've collected from certification and from other sources. But I would say largely focused on what we've got in-house now.
Just wondering, I think it may fit the brief too, and I don't know, again, confidentiality on things in play or how you aggregate this data if it's a narrative versus numbers-based approach. But I think one of the things we need to get at is around the use of long-term care services and supports, and the usage of nursing home versus rehab versus home care, and how each of the ACOs are thinking and working in that space. It seems like the big area to better understand, and I'm wondering if you see that playing out in here, or how we can get at that. It seems like we've seen it's a growing amount of money that we're spending each year in the healthcare system. Supposedly it plays an important role in trying to reduce costs. So I'm just trying to understand how we get that into the mix to better understand how ACOs are thinking about it.
Yeah.
Is that fit within there, or do we have the data to do that? Or?
I think it's partly in brief 6, where we talk about their relationships with different provider types. I think it's partly in the question we asked around. It may show up in some of the responses we got around population health management on the social determinants of health side. I think, but I'm thinking more brief 6 probably than brief 2.
I think timing-wise, the nursing home focus and post-acute care focus is very acute, fully intended in the Medicare space. So, so all ACOs that have Medicare, either previously Pioneer, now NextGen or SSP, have developed SNP networks that they monitor performance on and are starting to work with in different ways. We did see that in responses to 6, but we didn't ask a lot of qualitative information about the quality of that relationship. We just asked, do you have a relationship? And so I think we'll be fairly limited in that space. I am cognizant of time, and we do have guests here from out of town. So if you want to just do the timeline and take any final questions, and then we'll transition to the experts.
Great, happy to. The one idea I'll very quickly mention is that in addition to these 6 briefs, we have an idea that from time to time we may want to use other formats to report on some of this information. So we're thinking about topical short briefs, perhaps a webinar here or there, other ways that we can engage the community. So it might not just all be these written briefs. Okay, timeline. So here we are today discussing our proposal with you. As I said, toward the end of March, we're hoping to release that first brief on the intro to ACOs in Massachusetts, get out the second one sometime in May, and go from there. I think we'll learn a lot in doing the first couple. We certainly will want to be taking feedback as we put them out from anyone who's reading them and modify our approach accordingly. But hoping by the winter of 2019 that we'll have done a full reporting out of the information, and at that point we'll be looking forward to starting to engage with ACOs on round 2.
Just one question. So I know that I'm thinking about what policy changes an ACO would effectively be able to make for the second year. I think some of the lessons learned are in brief 6, but definitely not limited to brief 6. I think there are some key information points that will come that way. So should we be thinking about changing sequencing so that there's certain data points that we expect to come out of these briefs that will inform the legislature, policymakers to be able to implement in time for the ACOs to act on them and to incorporate them into their year 2.
That's a great point, and we would certainly be open to changing around the order of some of these. I think you're right that when it comes to forming different kinds of external relationships, that might take some time, so it might be helpful. So we can certainly think about moving that one earlier in the sequence. The other thing I'll say is that for sure, as we go through the balance of this year, probably before we are able to publish these briefs, we'll be internally gleaning some information about what's going on and where we might want to go with that second round of certification standards. We expect to be talking to each of the ACOs this fall. We're going to try to do a site visit with them, and I think that will be a good opportunity for us to have some dialogue about how things are going, what might change in the second year of certification, and then be able to talk with all of you before the end of the year about any revisions to our standards.
And then the only other thing I would just say is that I'm a little bit concerned about the additional reporting that could potentially come from this. And I appreciate your comments that you will try to use the data you have in the certification process and other sources available. But I think it would be helpful for us to know as the process is carried out, how much additional reporting you're asking, because the ACOs are also going to be, there's reporting requirements associated with mass health ACOs, and these are entities that are reporting to various, I don't know how to use this, but so the reporting burden is real, and I would just say that we should be cognizant of that as we want to go back, before we go back and ask for additional information.
Yes, thank you. And I should reiterate that we don't have plans to formally request additional information until such time as certification is up. We hope to engage with these systems. We plan to have conversations, but we are certainly mindful of the reporting burden they're already under. So I appreciate that.
Anything else? Captain, thank you.
Thank you.
All right, we want to move to our guests and invite them to come up.
So Hannah Kumak is our senior program associate, and she manages the leave no absence syndrome program. So she's going to introduce the team, give it a little bit of context, and then we'll hear directly from the Lawrence General about the program.
Great, thanks, Amy. So I'm just going to give a little bit of background information on where we're coming from and what we've been doing across the state in addressing this issue. And I'm really excited to let you hear from the Lawrence team about the program that they've been running for the last year. So over the past few years, the Commonwealth has taken a number of steps to enhance the care for infants who've been exposed to opioids in utero. Last year, the Health and Human Services and Attorney General's offices launched an interagency task force, which was really developed to look at how to improve access to services, identify gaps in services, and create a statewide dashboard looking at a lot of the key metrics on infants who've been exposed to opioids in utero. Our opioid use disorder report, which was published a year and a half ago now, drew a lot of similar conclusions that we've been looking at during those task force meetings and trying to address through our NAS programs. The opioid epidemic has driven demand for treatment for adults, but has also really called into focus the need for specialized care for infants who've been exposed to opioids. Massachusetts sees a particularly high rate of NAS. In 2009, the rate of NAS was 3 times the national average for the Commonwealth. And in 2014, and I think we're starting to look at some of the more recent years, but what we were seeing was a lot of NAS births were clustered regionally in Metro Boston, Fall River, New Bedford, the Berkshires, and the Cayman Islands. So last year, around this time, we launched implementation of our HCII program. As you remember, there's the 3 different pathways of this program: the targeted cost challenge investments, the telemedicine pilots, and the program we're talking about today, which is the mother and infant focused neonatal abstinence syndrome interventions. So our NAS program was really designed with the aim to provide enhanced care to infants who have been exposed to opioids in utero, and additionally provide wraparound services to women, pregnant and postpartum women with opioid use disorder. So there were 2 categories for funding. Category A, our target population was really focused specifically on infants, and the Category B programs also implemented the wraparound program that was providing care for mothers as well. So we awarded funding to 6 hospitals to implement these initiatives. It represented almost $3 million in funding. We have close to 60 organizations who are participating. That is hospitals, primary care practices, community health centers, MAT providers, and behavioral health providers all working together and working on this problem together. In 2015, this is the year that data was available when all of our awardees were submitting their applications for funding. Over 450 infants were treated for NAS at these 6 hospitals. So we made these 6 awards. Bay State Medical Center, Boston Medical Center, Lawrence General, and Mass Memorial are all implementing our inpatient program with the target population of infants exposed to opioids in utero. And then Leahy Health Beverly Hospital and Lowell General are also providing those wraparound services. So today we have Lawrence General here who's going to talk a little bit about what they've been doing with this program over the last year.
Thank you, Hannah, and thank you to the whole Health Policy Commission for inviting us. My name is Dan Hale, and I'm a pediatric hospital medicine physician. And this is Heather Top, our neonatal abstinence syndrome care coordinator. We're very happy to share some of our information results. Some goals for today. NAS and neonatal abstinence syndrome is kind of not well known what that means, so we want to talk about what that is. We want to review our specific 3 HPC goals that we have for the 2-year grant, and finally show some early results for 1 year in, and we're happy to say we've met all of our results already, so we hope to sustain and exceed them. But here's what Hannah said for the HPC grant is going after evidence-based models for treating NAS at these 6 hospitals, supporting women with opioid use disorder. This takes a village to help these babies. We're very proud of the state of Massachusetts in leading the country truly in fighting the opioid epidemic. And these babies are some of the silent victims of the epidemic. We need to do everything we can to tackle this epidemic, and start with the people in homeless shelters, people prescribing opioids to patients, high school education, and taking care of finding these babies now that we know more. NAS has been around since the 1800s. Opioids were widely developed. It was pretty rare to have NAS, and not a lot was known, but we know so much more now. As you can see, New England's some of the highest rates of neonatal abstinence syndrome in the country, northern New England and Massachusetts especially. And Lauren, sadly, has been making the New York Times and other papers because of the epidemic. This is an article in New Hampshire about a family, and they blame Massachusetts for bringing opioids across the border, which is a sad truth. I'm kidding, I'm friends with a lot of people in New Hampshire, and I can see New Hampshire from my house, but it's all over. Spreading. This is the birth rate with admissions for neonatal abstinence syndrome since the early 2000s. There's been a 5-fold increase in opioid withdrawal in newborns. So that's why we're hearing more about it. We have to standardize care and do more. The length of stay for these babies is oftentimes a month in the hospital. All these babies who are exposed to chronic opioids do withdraw after birth. The umbilical cord is cut, and within hours or days, these babies show signs of withdrawal. Any opioid or nicotine withdrawal, just shaking and crying and busting. So all of them go through this, but people didn't know what to do. They used to stick these babies in neonatal intensive care unit for a month, watching them. And we realized the new standard is really keeping these babies with their families. It's fascinating, the research that just bringing babies back to their parents works, of course, holding these babies, feeding these babies, and soothing them through this problem is the key finding. So we have to transition all of our hospitals in the move us back to that. One of the first steps that we always talked about, and even the Surgeon General brought up for the opioid epidemic, is starting with ourselves first. Stigma for this population and getting past these barriers. Almost 3/4 of patients who use heroin first use the prescribed opioid, either non-prescribed or prescribed. So they started using oxycodone, OxyContin before getting to heroin. So this isn't, you can't just label these patients. This is where that short video is. The HPC helped us create a 1-minute video kind of going over what this is and the scope of the problem. So we'd love to share to help summarize. Please interrupt with questions, of course, but we saved a lot of time at the end. Every day, over 90 Americans die of opioid overdose. In Massachusetts alone, there are over 5 deaths per day on average now. After the baby is born and starts withdrawing, we call that neonatal abstinence syndrome. We know so much more now that can be done for that. At Lawrence General Hospital, for years, they've created a program of trying to help these babies. One of the biggest things is keeping the mother and father together with their children.
I've been sober for 7 years now. I'm 42 years old. It's my baby Brooke. She was born June 29, 2017, and will receive her care at Lawrence General Hospital. This program was I was able to be there the whole time. I felt 100% supported by the doctors and the nurses. I was definitely provided with my education this time around, which helped out a lot.
When Martin Luther King encountered challenges, he always said that he'll choose love over hatred. The opioid epidemic absolutely created hatred, anger, and fear. At Lawrence General Hospital and boarding hospital for children, we choose love over fear. Thank you for participating in the teamwork on that. That was part of a large, pretty novel training program that we did for every nurse in our hospital, trying to, again, start with step 1 of not judging the patient. Jody did give permission to share this video at other hospitals, anyone who wants to use it, and thank you to Heather for working with her and all the nurses for sensitivity awareness in this. Jody, as she commented, there had a baby 5 years ago with neonatal abstinence syndrome, and she noticed like night and day the difference now that people aren't judging. She could stay in a room. A mom came over a couple weeks ago and said it felt like staying in a hotel. We tucked them in a room and offered whatever we could do for that family. We actually have had time magazine came to the hospital recently. They're releasing a special issue in a couple of weeks on the opioid epidemic. Everyone's working on this. It should be a full court press. And they profiled many patients around the country, and one woman who was pregnant, and so she knew her baby would go through withdrawal. She actually switched care to Lawrence General after the HBC grant because she had heard about it, that we were doing a novel program like this, and her baby did very well because she was very involved in the care. Briefly, what is NAS? Withdrawal in newborn looks a lot like a withdrawal in adult, but just a little different. 3 main areas: your neurologic system affected, your autonomic nervous system, so your heart and lungs, and then your gastrointestinal tract. You can't die from withdrawal for adults or children, but you can die from the side effects. So these babies sometimes would die in the past because they weren't being fed, they can't eat, those kind of things. So sometimes you do have to help them with medication. So the nervous system part is seizures sometimes, or jitteriness and shaking for these babies. They do have high heart rate and respiratory rates and fever sometimes. And finally, the feeding issues and diarrhea and things like that can affect their health. Any questions on that before we start going into more information? Thank you for your attention. The 3 large HBC goals are: number 1, aim is to reduce costs per episode. NAS routinely used to cost almost $50,000 per inpatient encounter, not counting the cost for the mother and outpatient follow-up. And that's when the babies went to the neonatal intensive care unit. So we want to reduce that cost, absolutely. The inpatient length of stay, obviously that drives cost. The babies don't need to be in the hospital for a month. They do go through withdrawal sadly for weeks and months at home. So it's not anything we're going to fix, we're supporting the family to the hardest part and then guiding them to their care network at home. We want to decrease that length of stay. And finally, increase the breastfeeding rate in this population. Breastfeeding is wonderful for all newborns who can do that, but especially this population. It's a double benefit of the families being closer to their baby. If you're breastfeeding, you're not going to be at home, you're going to be in the hospital with that baby. And also just that bonding and cuddling. Before, these babies were in the hospital a month, and then the families would basically come back. They'd be there for a month or two later and welcome this newborn into their home, so that bonding period was missed. And then finally, a little bit of the buprenorphine or Suboxone that the mother may have been on, or methadone goes through the breast milk to the baby. It's not toxic. It's such a low level that theoretically that probably helps the baby a little bit through the withdrawal. And we're happy to say we met all those goals. Heather was going to go over a little bit of summary of some changes we've done at Lawrence General Hospital.
Yeah, I'd like to point out that I went into labor the very next day after that video. So I'm the program coordinator at the hospital, also on the front line, I'm the social worker for the floor. So a lot of the things that we've been doing are similar to what we were doing a year ago. There's more emphasis on what we've been doing. So if you go down this list, we see that there's a dashboard. So real time keeping track of all the patients coming in, their names, date of births, drugs of choice. Are they in treatment? Are they not in treatment? Are they planning to breastfeed? The costs, like he was talking about. So those are just different pieces now. We can look at track and see how many women we have coming in per year. In January alone, we just doubled our number from last year. So we're having 3 women deliver last year, babies born with NAS to 6. So in January we had 5 women at one given time that we were treating. So that was a lot. It was a good test for the hospital to see how we can manage having quite a few women on the floor. In-hospital counseling and resources 5 times a week, or 5 days a week. I'm with the families multiple times a day, multiple times a week. Whatever they need, I'm there for them. I want to create an air of comfort for these families. That's the biggest part. I want them to engage in their treatment and feel like they're not judged, that they're accepted, they're more invested in the care for the babies if they feel that way. Just jumping around, we talked a lot about sensitivity. We had a sensitivity training that we put out in October where we gave the nurses an opportunity to talk about what are the hard parts about working with these families, what has worked well, so we can talk about best practices moving forward, what are our struggles. We had everyone take off their professional hats and create an image of a person. What does a substance abuser look like? What race are they? What ethnicity? What drugs are they using? What kind of job do they have? How many kids do they have? So I think it was an eye opener for everyone to come in and have an opportunity to talk about what's really on your mind. It's really important moving forward to address those biases. Employees have family members struggling with substance abuse. So that was a really successful intervention that we put in place in October for that. Prenatal tours and previewing, that's the most ideal situation for me. We are marketing a lot more this time around, so we have brochures and pamphlets that we're sending out to local providers just to say, if you have a woman who's pregnant who's either on prescribed opiates or non-prescribed opiates that you're aware of, please send them to us. I want to meet with them as early in pregnancy as possible. I'll provide support throughout the entire pregnancy, whether that's just a quick phone conversation, in-person meeting, they need counseling, and then you start getting things together for the baby. I'm there for that. So I think the OB offices have appreciated that, knowing that they can send their patient somewhere and feel like they're cared for. So that's been a plus. 2 times in the last 2 months I've had doctors call me from their appointments with the patient, sitting with them at the appointment to schedule a meeting with me. So that's the most ideal scenario. Scheduling real time, have them come in. It's about a 45-minute meeting. I get a background history on them and walk them through the entire process, where they start or where they finish. And they're supposed to remember every single piece of information that but that's why I meet them a lot. They have packets that they receive, and just to kind of address what are the scariest parts for you walking into the hospital. We have a woman that I met with last month for orientation. She just delivered yesterday. I went to see her this morning. She knows who I am. She knows who I am. She feels like she has, there's safety at comfort. She can talk to me. She can ask questions. I can walk in and say, I know your daughter's name. I can walk in. We know each other. So we already start off on a so our success levels, you know, proof in the pudding, right? So how much we're able to teach our patients is really important. Increased non-pharmacological management, that's important. So when the families come in, we talk about what's going to help your baby reduce the amount of withdrawal. So we talk about, you know, dimming the lights, keeping everything quiet, the less passing around with the baby, the better. Breastfeeding is really important. One of the big pushes we had over the last month is increasing cuddlers. Cutest thing of the time. We kind of went off of Boston hospitals.
BMC had
BMC.
started that.
Kind of over 100 cuddlers. They have 24 hours a day sitting with the babies, and it helps. That stimulation helps the baby produce their level of withdrawal. So we wanted to mimic that, and we put a feeler out internally to see if we can get any employees to hop on board with becoming a cuddler, and it quietly leaked out into the community, and we quickly within days had to start a wait list for the amount of people responding to this. So last year alone we had 241 hours worth of cuddling, and just last month we had 154. So in 1 month we are almost reaching what we reached all of last year in terms of how many people we have coming in to sit with these babies. It's really been very effective. We already talked about the sensitivity training that we're going to be moving towards creating a clinical educational module for the doctors.
Thank you, Heather. We're lucky to have you. And for the cuddlers, we went from 6 cuddlers a year ago who were on the volunteer staff, so very rare that we called. They happen to be available to over 180 people signed up, and we've trained almost 70 now. And they come for 1 to 3 hour shifts. And right now, up until 10 p.m., but we're exploring overnight as we train more. That's a picture on the left of our executive vice president of medical affairs. So we have the most senior cuddler in the whole state. And one of our neonatologists, Dr. Pereira from Floating Hospital for Children. This is our early data for length of stay reduction. That top orange line is how long the babies were in the hospital. The blue line, the amount of time they're in the neonatal intensive care unit. So starting in 2011, we had almost an average length of stay, like the rest of the country, 33 days for that year. So a whole month of very costly care. And then we started in that year, 2013, moving babies out of the intensive care unit to the pediatric ward where they could have their own room with their family. And you can see it continue to go down. There was an uptick the year before up to a 22-day length of stay the year before the HPC grant, because there was not an NAS task force. It wasn't a group looking at this. And instantly, within a couple months of the grant starting, the length of stay dropped. Like one of those things, you start focusing on it, and it does work. We got down to the lowest ever in history recorded at our hospital for the last reporting period, down to 5-day length of stay. That's almost the minimum we can do. Babies withdraw usually within 3 to 4 days after birth, so you have to watch them to make sure they don't go through that severe part at home. So most hospitals discharge a baby at about 5 days of life. So the fact that we had 7 babies in a row, what that was, the mom and dad were very involved. The baby stayed in their room. They didn't need any intensive care. So finally, the 3 measures the cost of care on average before the grant at our hospital was almost $24,000 per admission. Like we said, at children's hospitals, often $40,000 or $50,000 because they're using level 3 or level 4 neonatal intensive care unit. So a high cost. And we dropped last year already to $16,700 per admission. So a pretty good savings. Last year we're still doing the actual numbers of over $150,000. And this is at one medium-sized regional medical center. So if every hospital in Massachusetts, which is the goal of this, is create a packet to give to every hospital, did this, we would talk about millions of dollars. So thank you for your support in that. Breastfeeding rate went up by 70% with just education. A lot of these moms thought they couldn't breastfeed. They had used heroin, they're on methadone, they can't we want them to breastfeed. We want to give them permission and support them, and letting the staff know. The staff had not been updated in the new research, so quite a turnaround. We're happy with that. And using medication, sometimes you do need to give baby, it's that little droppers of liquid morphine to help them through that. Most of the time, people with withdrawal don't have to go on something. You support them, both the babies and adults. Sometimes someone does need methadone or buprenorphine, and for the baby, sometimes we do give them liquid morphine. That's for severe withdrawal, so seizures, not eating, really having a very hard neurologic condition with this. So most of them don't need that. So we decreased our use in the first year already by 57%. So less than half of the babies actually needed morphine from, we were over 80% needing morphine before. And our data has been recognized. The HPC name is on here for several presentations around the country already. This is our fall perinatal conference in Massachusetts, partnered with NeoQuick and HPC. This is our nurse training posters of the novel interventions that train every nurse in a timely manner in a sustained way. So that was accepted for the Massachusetts conference. And this has been accepted at 2 national conferences with HPC, Floating Hospital, and Lawrence General Hospital, of that length of stay data, showing how you can use intervention in small, frequent scale methods to decrease length of stay rapidly. So they're really jumping on this, like how do you roll this out? How do you scale this up at other hospitals? We have some more informational brochures that we're getting out. Any questions on that? We really appreciate your attention.
Doing wonderful work.
Thank you.
Thank you so much. Keep doing it. You will.
I just have 2 announcements. And then we can do them. So the 2 announcements are, we're having events on May 17th. Save the date. I'm partnering to address social determinants of health. So you'll hear a number of other presentations from really great clinical teams, like the team at Lawrence, and actually another team at Lawrence will be presenting at this, and their community partners. So school, behavioral health provider, housing provider will be presenting on panel 1 about how they work together and what works. Panel 2 will be policy discussion about what policy changes may be needed to sustain those partnerships. We have Dr. Alice Chen from San Francisco flying in. She's an amazing speaker. If you haven't heard her before, she's the deputy director of the San Francisco Health Network and a primary care clinician herself. So save the date. The other announcement is the Shift Care RFR is still out there. Please submit your questions to the procurement box if you have them. We will be issuing a couple important clarifications in the RFR later this week based on some questions that we've received through the frequently asked questions process. So watch that space.
Public commissioners, any other points? If not, I have a motion to adjourn. Thank you. Happy Valentine's Day.
How's Kelsey Valentine's?
Finding out.